This is Dr. Brad Elder presenting the topic local therapy for gliomas on behalf of myself and Dr. Russ Lonzer. So what I wanted to present today are examples of different local therapy treatment options for patients with glioblastoma. The patient shown in this slide has a recurrent glioblastoma in the left frontal lobe. A different patient has a recurrent glioblastoma in the left parietal lobe, and then a third patient has a recurrent glioblastoma again in the left frontal lobe. And these are just some examples of uh, patients with recurrence, and each of these was treated using a different local therapy. When we discuss gliomas and glioblastomas, we start with the understanding that these tumors are incurable, that they invariably recur despite maximal therapy, and that they are uniformly fatal. Treatment options for newly diagnosed gliomas include the standard surgery, radiation, and temozolomide. Uh, Options also can include laser thermal therapy and clinical trials, although these are clearly experimental. For recurrent gliomas, repeat surgery is typically entertained if possible. Reirradiation may or may not be possible and depends on the time frame from the prior radiation. Switching systemic therapy, bringing in thermal therapy, and of course investigating options in terms of clinical trials are also options. But the lack of truly effective options makes it more important in terms of makes the clinical research more important, and this includes study of potential local therapies for efficacy. So looking at our three examples, our three cases from the beginning, this was the first left frontal tumor, and in this example, we opted to do convection-enhanced delivery in the form of a clinical trial. As part of this trial, the patient first had maximal safe resection of their left frontal tumor. Here we see a preoperative image on the left and a postoperative image on the right, showing resection of the recurrent left frontal enhancing lesion. And then these CAT scans show placement of multiple catheters that were used for convection-enhanced delivery. These catheters were placed into the parenchyma surrounding the tumor, and this largely included the areas targeted for infusion were the areas that had high hyperintense T2 or flare signal on the preoperative MRI, suggestive of peritumoral edema. Thought to be the area of most likely recurrence after treatment. So these two CT scans show cuts through the catheters. This patient was enrolled in a clinical trial that involved convection-enhanced delivery of carboplatin, and 54 milliliters were infused over a period of 72 hours, and it was a dose escalation study, so the concentration changed with increasing doses of the 54 milliliters. And CED has been used for many different agents as part of different clinical trials. And this is not only different agents, but also different volumes, different time frames for infusion, and remains an area of interest for investigators pursuing novel treatments for glioblastoma. The second patient in the original three patients with the left parietal tumor underwent viral-based gene therapy. This strategy involved resection of the recurrent tumor, and in this patient's case, this tumor had recurred approximately 9 months after his initial treatment, which involved surgery, radiation, and temozolomide. After resection, the resection cavity walls were injected multiple times with a replicating retrovirus, which encoded cytosine deaminase, capable of converting 5-FC to 5-FU. And then approximately 6 weeks after surgery, the patient began uh, therapy with the long-acting orally administered 5-FC. Immediately after surgery, we see the extent of resection. We see all the enhancing component had been removed. And this was for this clinical trial. This patient was by far our best performer, achieving no evidence of recurrence with no additional therapy 5 years after surgery. The third patient on the list, or on the in the examples shown from the beginning, had another left frontal tumor. This patient had undergone a craniectomy. She initially presented as a transfer from an outside facility. She had undergone a partial resection of a glioblastoma. Unfortunately, she had suffered an infection, was transferred to our facility, at which point she underwent completion of the resection of her original tumor, as well as a craniectomy. Given the surgeries that she had been through, she was not interested in another resection and was offered laser thermal therapy for her recurrence. This is a local therapy that involves heating tissue beyond the point of cell viability. The setup for this patient is shown here. The patient is situated in the MRI magnet. A MRI compatible targeting platform has been attached percutaneously to her skull, and the laser will be inserted, which is being held in the front view of the image, will be inserted via this targeting platform to various points within the lesion, and the MR thermography will identify the heating of the target tissue beyond the point of cell viability, and in this way the lesion will be thermally ablated. Here's a screen cap of the targeting software. The right and left is flipped on this screen, just as per how the software handles the imaging. In addition, some of the enhancement and has been washed out as this is into the planning a little bit. So sequential MRIs show gradual washing out of the contrast enhancement. And then here's a picture of the laser ablation procedure and the MR thermography with the heat map on the left side and the orange on the right side showing the area that's been heated beyond cell viability. And then lastly, a post-procedure image showing the fairly well-delineated area that's been treated. So this wasn't one of the original 3 MRIs that I had up, but this is another example of local therapy used for treating recurrent high-grade glioma. In this case, a patient had undergone a left temporal resection of a left temporal glioblastoma, and at the time of recurrence, it was felt the patient was not a candidate for open surgery, and was offered a clinical trial involving the stereotactic infusion and convectionist delivery of an oncolytic virus into tumors, into recurrent glioblastomas. This is a magnified view of the patient's medial left temporal tumor that was done after placing a convection enhanced delivery cannula using MR guidance into the tumor. This cannula was placed in a similar fashion as the laser thermal therapy laser, and then the infusion proceeded to infuse the oncolytic virus into the tumor. Here's the preoperative image on the left and a 6-month post-infusion MRI on the right side showing cavitation and decreased enhancement of the lesion. Finally, this is an example of local therapy for a brainstem tumor. Note the tumor involving the brainstem in this pediatric patient. Here's a coronal image of the tumor, which is noted to be hypointense on this T1 contrast-enhanced scan. Here's the area of the tumor targeted for infusion. And then here are screen caps at different time points of the infusion proceeding. We see the infusate, which involves a co-infusion with gadolinium occurring within the brainstem and gradually filling the targeted volume of distribution. And then this is a final image showing the volume of distribution of the infusate. This is the last slide. I'd like to thank everybody for listening and to the topic, and I hope the examples were interesting and accompanied and complemented the information in the chapter well. Thank you.